Slidell Memorial Hospital, your hospital for life.
Hello and welcome to another edition of HealthQuest, St. Tammany's response to meeting the medical information needs of you, the citizens of our parish. My name is Bruce Clement. I am the executive producer and host of the show. Today it's my pleasure to welcome back Dr. Matthew McElveen. Dr. McElveen is the medical director of the Slidell Memorial Hospital Regional Cancer Center, a practicing medical oncologist at the Cancer Center, a good friend of the community and of HealthQuest. We thank you so much for sharing your time with us today, Dr. McElveen.
Thank you for having me.
We are approaching what is Breast Cancer Awareness Month in October, and what we want to do today is to revisit a topic that's very timely, very important, and has had a few changes over the last several years. So this is a good opportunity for us to go back and look at some new material and to make sure that we're all on the same page with the contemporary thinking as far as breast cancer screening. So Dr. McElveen, welcome back. Tell us about the scope of the problem.
Breast cancer is such a common disease, not only in our country but worldwide. And of course the most common cancer in our disease is skin cancer. Skin cancer doesn't kill nearly as many people as breast cancer does. And among women, it's actually second in death rates only to lung cancer. The incidence of this disease had been increasing, and we think in a large part that may have been due to screening and our techniques at finding this and getting better at identifying these things. But in 2017, they had approximately 250,000 new cases, and we have near 40,000 deaths every year. So it's a very common disease. It probably is the bulk of my practice. Is breast cancer, along with some of the other more common cancers. So safe to say that we see a lot of that.
The important thing that we ought to talk about, or one of the many important things that we're going to talk about, are some of the cause and risk factors of breast cancer. And there are many. There are many more. When I was doing the research on this, I was very surprised to read some of the things that are associated with this. So take us through some of the more prevalent causation factors.
Sure. And understanding the risk factors, I think, we have to ask ourselves, why do we do that? It really comes back to how we adequately screen patients. Like you said at the beginning of the show here, things have been changing a little bit, and we're addressing patients based on their level of risk. Now, and the way we do that is by identifying certain things about people that may bring them there. A family history, this is a hereditary disease. So if you have a family history, then we are very cautious about how we screen those patients. And of course, the age at diagnosis of that family member plays a big factor, i.e. younger patients diagnosed typically have more aggressive diseases and typically have a higher hereditary component. Everyone has heard of the genetic aspects of this. It actually plays a relatively small role. Separate from family history. Family history is a genetics issue, but there's a gene mutation called BRCA1, BRCA2, or BRCA is what we call them. And those, they represent a small amount of breast cancer, but patients who have this genetic mutation can in some situations have an 80% lifetime risk of getting breast cancer. So that's a little different subset. Other things that we see more commonly, women who begin their menstruation cycles later in life or earlier in life, or who have very few children or no children or have late childbearing, that places them at an increased risk. Just simple moderate daily alcohol use, a glass or two of wine, has been associated with an increased risk of breast cancer, as have the use of hormone replacement therapy past menopause. So, and there's many more of these things that your physician will use to make a judgment on how and when to appropriately screen.
Now, there's a thought out there about the density of the breast having some impact on that. Mm-hmm. We have some correlation studies that will show that.
Yeah, there's two concerns with it. Is there a true increase incidence in women with dense breast? I think that question is somewhat unresolved, but a bigger problem is they're difficult to screen. Mammography has a more difficult time screening dense breasts than it does in less dense breasts.
Now, those are some of the risk factors. Now, if we want to talk about, there are some factors out there that can actually be protective, quote unquote, protective for this disease. What are those?
There are several things. A lot of this is just healthy lifestyle. And maintaining your weight at a reasonable level, eating relatively low-fat diets, of course, avoidance of smoking. Smoking impacts many different types of cancers, breast cancer among them. The physical activity kind of goes back to this healthy lifestyle, but it seems to correlate well that women who are more physically active tend to have a less incidence of breast cancer. And then, as we talked about, a risk factor being no children or late children, the woman who has several children is somewhat protected.
And what do you attribute that to, or is there some science out there that speaks to that?
What we think it is an estrogen exposure issue. So if I go back to my earlier comment of starting menstruation early, you have estrogen exposure early, so you have estrogen exposure for a longer period of your life. And most of the time there's no problems with that, but we know that the longer you have that, the higher your risk is. When you're pregnant, your estrogen levels will go down, and so during that period of pregnancy, you have less exposure. So if you have 1, 2, 3, 4, or 5 children, you're not quite a year that you're without that exposure. And we think that's where that protective effect comes from.
So there has been definite correlation between estrogen exposure and incidence of breast cancer?
There has been. I will caution you that the studies can be confusing. I would say that where I have the highest degree of concern, because there's very little you can do about a girl who starts her menstrual cycle early. You just got to be careful. What I caution you is hormone replacement therapy after menopause. All right, so women go through menopause typically between 48, 52 years of age, which is what's most typical. That's kind of supposed to happen. And the avoidance of the hot flashes and the symptoms associated with that is why hormone replacement was used in the first place. That estrogen exposure beyond menopause is probably the biggest risk.
All right. So we're going to talk about screening now, and why do we screen? Mm-hmm. What are the values here?
If you look at the slide here that's up, obviously we do see a clear benefit. The reduction in mortality up to 20% is an interesting number. It actually you can kind of parse this number apart a little bit, because the real benefit tends to happen in older women. And that's part of where some of this has changed. So if I were to break out, so to speak, the mortality improvement based on decades, so from 40 to 50 years old, those women have about an 8% reduction in mortality, that's nothing to pass over, right? And for each decade, it basically doubles. So from 50 to 60, it goes to about 15. And then from 60 to 70, mid-70s, it's about 30%. reduction in mortality. So if you lump them all together, you come up with that number there. So it's a the mammography and screening has its best role in patients who are a little bit older, but certainly is beneficial in a younger patient as well.
Now, there are different screening tests. Take us through what those different tests are and how that works.
Well, far and away, mammography is the predominant test that we use. It has the best data associated with it in improvement of mortality. What you'll see listed here is ultrasound. That typically goes as a caveat to mammography. We don't usually do ultrasound by itself. There are some areas where we may. But what happens most of the time, if you have an abnormal screening mammography, we'll go back and add an ultrasound to that. So some women think that when they get screened, they're going to get a mammogram and ultrasound. That's not the case. Historically, we used mammography, a clinical breast exam or physician breast exam, and then a monthly self-breast exam for patients. Some of these things are changing because, as we continue to look at the data, you can see that a clinical breast exam, how effective really is it? If you look hard at the data and the studies that have been done, it doesn't look like it's that effective. They say the same thing about monthly self-breast exams, but I will tell you that I would never tell a lady not to do monthly self-breast exams because of what this data sees. Because I promise you that far and away, the patients I get have noticed a change in their breast and seeked out a mammogram, especially the young ones. And if they're not paying attention, then they're not going to find it, or they'll find it late. And that's an obvious problem.
And that's a low-cost approach to doing a quick check.
There's no doubt about it.
I want to back up a minute and go back to mammograms, because we've had some dramatic improvements in technology in the last 7 years, in that we've gone from two-dimensional mammography to three-dimensional mammography. What is the difference in those two, and how does that benefit you as a physician?
So a two-dimensional is exactly that. You get two pictures. Okay, so and it's a good test, and if that's all you have, then that's fine. But it can oftentimes see areas of the breast that may shelter or hide suspicious areas, because there might be an area of tissue that's folded upon itself, or you just don't have enough of that imaging. A three-dimensional adds, I guess the best way to explain it is it adds multiple images. It adds a lateral dimension and a vertical dimension, and then from front to back, if you will. So the radiologist now has the ability to look at the breast using several different images, and if there is an area that looks kind of odd because perhaps the tissue was positioned, inappropriately, or it just happened that way, they can usually ferret that out because of all this extra imaging that's done as part of a 3D mammography. It has increased our ability to identify suspicious tumors, or suspicious findings.
So what we see here in mammography is a great technological advance that gives you earlier opportunity for diagnosis. And one of the other things that I've read on the new types of mammography, the new 3D mammography systems, is the dose of radiation is down. The dose has been lowered. So something very, very important if a woman is going to have these for decades, these tests for decades. Dr. McElveen, you mentioned earlier that there were genetic components, family history involved in risk factors and causation. Could you do a deeper dive into that and educate us on what is going on there relative to genetics and the family history?
Most certainly. As I said before, there's certainly a genetic component to breast cancer, and family history plays a big role. I think patients do get confused oftentimes about what types of genetic tests and genes perhaps are available or are known. We know that this is an inherited disease because we've seen it spread through family members and down family lines. This is very well documented. The fact is that we have not identified every gene by which breast cancer may travel on. It's a very complex issue when it comes to that. Now, separate that from the breast cancer gene, which is one that we did identify. The breast cancer gene is so prominent in its risk that it's hard to ignore that there's some obvious problem. These families have multiple members that have breast cancer, multiple members that have ovarian cancer. They come to you as a physician saying, I have a problem. I have 2 sisters, a cousin, a mother, and a grandmother that have had breast cancer. And right away you can know that they probably have this breast cancer gene, that is the BRCA1 or BRCA2. And there is available testing for that. There is not really, however, a lot of testing for your traditional or your more commonly inherited breast cancer, which you see throughout many families. But of course, it doesn't have near the risk as does BRCA. If we identify a BRCA mutation in a patient, that changes things for them. And it can change things in very dramatic ways. Again, if somebody comes to you and says, you know, if you have an 80% risk of getting cancer, unless you do a bilateral mastectomy or surgical removal of both breasts, what is your decision going to be? And most women don't really mince with that decision too long. Some do, but it's a very it can be a very challenging problem, because most of the times when we define these things or we find these things, it is in a younger patient. And these younger patients almost always have more aggressive disease to begin with. And then you add on top of that, oh, by the way, your risk of having a second one is 60, 70, 80%.
So the ability to know that these BRCA genes are there is available to us because now we have a way to test for them.
Oh, most definitely, yeah. For the BRCA genetic testing, we do, and there's fairly standard protocol for who we will screen for that, and it has as part of that, there's many different things that I look at, and I keep a sheet on my desk that tells me, you know, if you have this, and this, and then it's time to test. But I can tell you that any woman that develops breast cancer under the age of 45 deserves this test, regardless of their family history. But if they have 2 first-degree relatives, and then they'll get tested. If they're a little older, perhaps above 50, and 2 first-degree relatives and perhaps another second-degrry, that may be a reason to test. So it's not a disease that hides from you. It's one that, like I said, a lot of times patients will come to you and say, we have an issue here, I need to be tested.
Yeah, and so, you know, our program today, our topic today is the importance of screening. And we see what you've educated us on so far is that screening really is a spectrum, isn't it? It goes all the way from self-breast examination all the way to genetic testing, and there are a lot of things in between. So let's now move to some recommendations of, you know, what do we do with mammograms at what ages and the different types of tests. And there have been a few changes over the years.
Mm-hmm. There have. The first thing I would like to say is you have to have a discussion with your physician about risk. Okay, so what we're going to describe here is average risk. Okay, so there's a lot of things taken out of that. You know, if you have a family history at all, you need to talk to your physician about what that represents. If you have multiple family members, you have to speak to them, because this average risk is not going to suit you. Yours is going to be different. Now, that being said, average risk, and that is, I will say, just not having a history of personal history of breast cancer, or not having a family history, that most women should know that they're going to be starting mammograms at 40 years of age. What we typically do, and what historically we've done, is done yearly mammograms. That is changing a little bit to every other year in some situations. It depends on which agency you look at. The U.S. Services, Preventive Task Services, they are recommending every other year to start. But if you look at the International Society of Radiology, I think is what it's called, they are still yearly. So you can pick apart which one you want to use and do that. And a lot of physicians, I will tell you, are still doing yearly mammograms. Okay, it's not necessarily wrong. But if you look to Europe, they're going every 3 years now in average risk patients. Canada is pretty solidly every 2. In the United States, this is what we're doing now. If you look on the slide, women 40 to 44, they have an option to begin yearly or every other. Between 45 and 54, we're doing recommending yearly mammograms, and I'll get into that more in a moment. And above 55, we're at every other year. Now, if you think about what I said earlier, how mammogram helps save more lives in older women, you might ask a question, then why are you going to every 2 years where the incidence of the disease is higher? Just taking all women across an average risk across our country, they have about a 12% lifetime risk of breast cancer. That's what it is. That risk is broken up by decades, so if you're younger than 40, that risk is probably 0.03%. From 40 to 50, it might be 2%. From 50 to 60, it might be more like 4.5%, 60 to 70, 5%. And you get, those are not exact numbers, they're close, but you'll get a sum up to 12%. But what we realize is that for women that are 40 to 44, their risk is so low that they really just don't benefit from that rigorous yearly mammography. It is very low. And look, I do see them. And if you came and looked at my practice on a day in, day out basis, you say, wow, you got a lot of young people. Well, of course, mine is going to be biased because I'm taking care of cancer patients. From 45 to 54, I think what you see there is you have the biggest capture of breast cancer by doing that yearly, and I think that has to do with the fact that the breasts are becoming less dense, and mammography is getting better because of that. Their risk parameters, so to speak, can be relatively high, especially in that 50 to 54. So you'll capture more of that. But I think what this really tells us is that in that window, that younger woman window, is that they tend to be diagnosed with more aggressive cancers, faster growing cancers. So it would help a patient to find that faster grower earlier, which is what a yearly mammography does. As you get older, the cancers become less aggressive, they grow more slowly, which is, I think, why they open up to every 2 years after 55.
I see. Now, what about clinical breast exams in the ACS?
ACS no longer recommending this. I don't know if our OBGYNs are happy or sad about this. I don't know. And again,
doesn't hurt.
It doesn't hurt. And I perform clinical breast exams on my breast cancer patients for the rest of their lives, because I think it can be a valuable tool. We talked about this a little bit before, is the monthly self-breast exam. I just can't tell you how many women find their own tumors and bring it to our attention. So although, yes, the data may say that this doesn't add a lot to mortality in screening, certainly not near the level that mammography does. I would not discourage a monthly self-breast exam.
Absolutely.
These ladies need to know their body. They need to know when something's different.
Sure. And then our final slide.
Okay, summary recommendations in high-risk patients. So again, this is where you really need to visit your physician to find out what type of risk you have. It's hard to, there's a lot of things that go into this. There's a lot of different computer models that our physicians use to generate risk profiles and you know, when you should or should you start earlier? What's the benefit of doing mammograms at the age of 30? Those sorts of things. Or more involved screening, such as MRI, those sorts of things. So we have some other tools that we would use here for a high-risk patient. I would tell you that any lady that's got a parent or first-degree relative that had breast cancer before the age of 50 need to seek out their physician's recommendation prior to the age of 30. They need to know what the recommendations are, because we'll often start those mammograms approximately 10 years earlier than that age of diagnosis of that first-degree relative. And if that was 45, then you're starting at 35. And based on what they see, you might need more than just simple mammography.
Sure.
So it's a different dynamic.
So we've seen some changes. We've seen some advances, a lot of good things. Reinforced today many times the importance of making sure that women know their bodies and that they communicate with their physicians if they know anything different, if they feel anything's different going on. Dr. McElveen, once again, we congratulate you on your leadership at the Regional Cancer Center at Slaughter Memorial Hospital.
Thank you.
We thank you for your time today and your knowledge and sharing it with us. From all of us at HealthQuest, we thank you for joining us today. Have a healthy day.